Welcome back, everyone. This event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status.
It's my pleasure to introduce Dr. Khandelwal. She is an associate professor at the Rush Medical College Department of Internal Medicine. She's the associate program director of the Rush Internal Medicine Residency Program. Dr. Khandelwal received her MD from Michigan State University. She completed her residency, chief residency, and fellowship training at Rush University. She is the co-director of the Rush Osteoporosis Treatment Center. Thank you, Dr. Khandelwal, for being here.
Okay, good morning, everybody. Thank you again for this opportunity. I thank my colleagues, Dr. Jolly, Dr. Nika, Dr. Sequeira, and of course, Mary, for this opportunity. So I'm going to spend the next, hopefully, 35 minutes speaking to you about osteoporosis. I am one of the co-directors of our osteoporosis clinic here at Rush. And for lupus patients, osteoporosis is particularly of importance, and I will share those things with you. So osteoporosis is a chronic, potentially debilitating condition which occurs as our aging population grows and is an increased case of mortality and morbidity. According to National Health Surveys, which is the NHANES, and as well as the National Osteoporosis Foundation, 10 million Americans have osteoporosis, an additional 33.6 million have low bone density at the hip. About 1 out of every 2 Caucasian women will experience an osteoporosis-related fracture at some point in her lifetime, as will approximately 1 in 5 men. According to the WHO, the prevalence of osteoporosis among U.S. white women is estimated to almost every decade of life increase. So for individuals who are 50 to 59 years, 14% incidence. For those 60 to 69 years, 22% incidence. And for those in their 8th decade of life, almost 70%. The significant risk has also been reported in people of all ethnicities, but particularly white and Asian racial groups have a higher risk. Why is osteoporosis significant? So here, this slide nicely shows you the incidence annually of breast cancer, stroke, heart attack, and this is again in women, given that most women are dealing with osteoporosis. And combined vertebral, pelvic, wrist, hip, and all site fractures is almost tenfold. And then finally, there is an economic burden. Osteoporosis-related fractures create a heavy economic burden, almost 432 hospitalized admissions per year, 2.5 million medical office visits, and over 180 nursing home admissions. The cost to the healthcare system has been estimated to be around $17 billion for osteoporosis-related fractures. Due to the aging population and that we have longer longevity of life, the Surgeon General estimates that hip fractures may double or triple by the year 2040. So today I'd like to just briefly discuss the pathophysiology of osteoporosis, understanding some of the treatment management guidelines, specifically talking about why lupus patients are particularly at risk, understanding what it means to screen for osteoporosis, but as well as how a bone density is done, and then finally ending with some of the lifestyle medication treatment options. So this is a great pictorial representation of our bone and what's happening on a weekly basis and then on a monthly basis. So this is resting bone, and by the age of 24, our bone mass in our body has been established. So I still recall growing up, I have an uncle who's a rheumatologist, that he's like, drink milk, eat yogurt. Your bone mass is built by the age of 20, 24, and then it actually plateaus. And then once we start aging and hit menopause, it starts to decline. So your peak bone mass is built by the age of in your mid 20s. And then from then there is this constant resorption, reversal, bone formation, and then mineralization. And so I'm not going to get in and delve too much into the pathophysiology, but the two cell lines that are involved are osteoclast and then osteoblast. Osteoclasts are what basically are kind of getting rid of the old bone, and then osteoblasts are building new bone. And this process is very active in our early life, but then as we age, it kind of becomes much more stagnant. Postmenopausal osteoporosis is actually a very well-known phenomenon. So this is a very nice pictorial representation of men and women, men being in purple, women being in green, and at the bottom is age. And so you can see very clearly that, right at the age, right around menopause, women take a very precipitous decline in their bone mineral density, which is this area right here. Men, on the other hand, are a little bit stagnant and then again do decline with age. So for women, once menopause is reached, there is an abrupt acceleration in the rate of bone loss, which persists for some reports say 5 years, some say about 10 years. And this accelerated bone loss is actually also very well documented in patients with inflammatory conditions such as lupus, rheumatoid arthritis, other conditions such as liver disease, other bone mineral disorders, as well as this is also reported in patients who are on steroids. So how do we diagnose osteoporosis? So I'm sure all of you, that's what we need to do. And those of you who are being managed by physicians, hopefully you have had some opportunity to delve into what your bone density is. So all postmenopausal women and men aged 50 and older should be evaluated clinically for osteoporosis risk in order to determine if you are appropriate for a bone density screen. And so what that means is based on your medical history, medications, lifestyle habits, history of adult fractures, the treating physician may decide to get a bone density test. Particularly in lupus, what places you at risk for bone loss? Female gender. As I've already shared with you, women are at increased risk of bone loss. Chronic inflammation, we very well have established in other medical conditions that we treat as rheumatologists that inflammation actually has a direct effect on the bone, and that then can lead to bone loss. Periods of decreased activity, many of you have had hospitalizations, have dealt with neuromuscular disease related to lupus, and because of those times of inactivity, immobility, you are actually not stressing your bone and actually being active, and that leads to bone loss. Risk for falls, again, because of various medications, because of neuromuscular disease, your balance may be off. You may actually have a more increased risk for propensity for falls. And then, as I mentioned, again, medications. Many patients with lupus are on medications that actually prematurely may induce menopause. And of course, steroids have a very direct effect on increasing that osteoclastic activity, those bone cells that are actually going to lead to more bone breakdown compared to bone buildup. And this is a great slide from the NOF, the National Osteoporosis Foundation, that really shares lifestyle factors, genetic factors, other medical disorders. I'll highlight calcium intake and vitamin D insufficiency as things that we all can do to improve our bone health. Of course, rheumatologic disease, lupus, is mentioned as one of the risk factors. And then particular risk factors for falls, loose throw rugs in your room, low level lighting, depression, malnutrition, impaired transfer and mobility are all things that, irregardless of our medical conditions, lead to bone loss. So if a clinician or a discussion between you and your physician feels that you need a workup for bone loss, the first thing we may consider is some basic labs, including basic blood counts, vitamin D levels, testosterone levels in men, calcium and phosphate levels. Of course, as I've already mentioned, if you already have a diagnosis of lupus, that is in itself a clinical risk factor. If you're already on steroids, that in itself is a clinical risk factor. If you've had a adult fracture, and the reason I say adult fracture, childhood fractures are actually not characterized as fragility fractures. Many of us have had fractures because of falls as a child or low intensity trauma, and those aren't really characterized as true fragility fractures because you hadn't built your peak bone mass. Your peak bone mass, as I mentioned, was built by the time of age 25 or so. And so fractures after that age that are non-traumatic, not from falling off a bicycle, not from a car accident, are truly something that you should mention to your treating physician. So if there is, based on that discussion, decided that there is a high clinical risk, and as I mentioned, you having lupus or a possible diagnosis of lupus does actually lead to that, then the next step would be assessing your bone density using the most commonly and most evidence-based technique, which is called a DEXA scan. It stands for dual energy X-ray absorptiometry, and it actually measures your bone density at the hip and the spine. So a common question I get from my patients is why the hip and the spine? The hip and the spine actually have a bone that is called trabecular bone. So what that means is it's almost like a lattice-like, if you think of like a net. That bone is not like a tree trunk, it's actually like a lattice, and so you can imagine small losses of bone density in that network can actually lead to very increased risk for fragility fractures. And then the bone density is then expressed in what's called a standard deviation above or below the mean. So one standard deviation above the mean would mean that compared to a 25-year-old person that is ethnicity matched, you actually have increased bone density. So what are reasons for increased bone density would be sometimes osteoarthritis, because you're actually having increased bone production from osteoarthritis that may falsely elevate your bone density. In most cases, obviously, as you age, the bone density would actually be 1 standard deviation, 1.5 standard deviations, 2 standard deviations below that of a normal aged adult. So this is what a DEXA scan looks like. It is a very non-painful, non-torturous test. So when your patient, when your clinician tells you to get a bone density, don't be afraid. It's quite painless. The test itself has what's called a C-arm that kind of goes over your body, over the areas that I mentioned, so over the hips and then over the spine. Sometimes we will also check the radius. A reason that a doctor may order a radius scan is, let's say you've had some surgery in the spine or you've had hip replacements, so they may add another site to get more information about your bones. The bone density is, we have it on site here. Many places have it. It's often done in radiology suites. Compared to the radiation, let's say of a chest x-ray, it's almost 5 times less, so much less radiation, so I would not worry about it in terms of that risk. The only other contraindications that you will be made aware of when scheduling is if you've had a recent barium study or anything where you've had contrast in your system for other tests that can falsely change the results of the bone density, so you're asked to wait a couple weeks. But otherwise, hip replacement, having architecture changes in your bones because of surgeries is not a contraindication. So what, as a clinician or your provider who's ordered the test, this is kind of the result of what we get. And the bone density, as said, is done at the hip and at the lumbar spine, the lower spine. Green here represents normal bone density. Yellow is bone density that's osteopenia, which is about 1 to 1.5 standard deviations below normal. And then the red is osteoporosis, where the bone density is 2.5 standard deviations below that of a normal young adult. And so here, this is a representation of where this bone density falls. It falls into the osteopenia range. So again, normal, osteopenia, and then osteoporosis. Again, this is a little bit of a closer view of this patient's bone density, where they fall -2 standard deviations below normal, and that is their T-score. A Z-score compares you to someone in your age group. So the Z-score should be very close to what your age-matched individuals would have. And again, the definition. So normal bone density is within 1 standard deviation of a young adult. Low bone mass is between -1 and -2.5. And then osteoporosis is anything lower than 2.5. The only thing I will highlight is that these definitions are necessary to establish the presence of osteoporosis, but they don't tell us the full answer. So some individuals may have osteopenia, which is, -2.3. However, they've had multiple fractures. So I may actually clinically call them osteoporotic because of the number of fractures that they've sustained in their life. And then the final piece is, of course, treatment. What can we as individuals do to treat osteoporosis and to some degree prevent it? So first and foremost, exercise. We have once, time and again, it's been validated that exercise increases bone strength by small gains in bone mass. Weight bearing actually improves bone mass, but also in addition prevents falls. Weight bearing aerobic exercises that are actually very good to help strengthen the bone include walking, low impact aerobics, elliptical, any flexibility exercises, Tai Chi, balance exercises, all actually have been shown to be very helpful. Now, one of the questions that I get often from patients is, well, I have, much worse bone density in my spine, or I've had a compression fracture in my spine. I've already developed a little bit of the hump. None of these exercises will help my spine. And the reality is that actually stability and balance exercises, Tai Chi specifically, will actually help to strengthen the muscles along the spine and actually can be very helpful to strengthen the spine bone. The other important thing is, I'm going to show this slide first, is good posture. So when we talk about helping the back, these are really some great stances and maneuvers that really can take pressure off of that mid-thoracic and mid-lumbar area. So for instance, standing at the counter, most of us probably stand like this with our hips, out, kind of the belly out. This is actually the better way to stand, a better stance to protect the back and actually prevent the back from having too much pressure. Tying your shoes. All of us bend right at the hip, and bending at the hip and adds actually increased pressure, intrathoracic pressure to the spine, and actually may add to some risk of bone loss and worsening of the spine. And then again here, sitting at a chair or a desk, anything that is causing you to flex your neck and bend your hips actually adds to pressure at the spine. In regards to other exercises, what do I avoid? These activities actually increase compression in your spine and can lead to fractures. So anything like jumping, running, jogging actually is high intensity and can lead to more pressure in that thoracic spine. I hate to tell, I have so many, I'm always embarrassed when I have a 75-year-old that tells me that she runs 20 miles or whatever. And so I don't want to take away that from you. I understand that there's so much personal well-being that comes from high intensity exercises and people that have been running all their life. So what I share with them is maybe just making it a little bit less time, making sure that they have good fitting shoes, making sure that they have controlled movements. If they start to feel off balance, maybe to walk in faster instead of running and things like that. And then, as I mentioned, the bending forward, any of the Pilates exercises or yoga exercises where you're actually doing crunches, bending at the hip, does add pressure at the spine. So those are things to avoid. Other lifestyle changes to avoid boinless. Smoking. It's very well been documented that smoking causes a direct toxic effect to the bone. Many studies have shown that people who smoke have lower bone density at the hips and the spine. And so if that is one lifestyle change you can make to help your bone loss, that would be a very, very good one. Alcohol, it's been reported again that greater than 3 drinks per day is associated with an increased risk of falls and fracture risk. It's a little bit debated if alcohol has a direct effect on the bone or if it's actually because people may be having more balance issues that they're having fractures. Caffeine intake, another one which I completely understand because I have to have 2 cups of coffee a day. So I tell my patients 2 cups is great, but anything more than that, you may actually lead to decreased calcium absorption. So the way caffeine works in our body, it actually decreases calcium absorption and to some degree vitamin D absorption. So the recommendation is to limit intake of coffee or soda to about 6 to 8 ounces per day. And then vitamins. Calcium and vitamin D, we know, have a very favorable effect on helping decrease that bone turnover and reducing fracture risk. So calcium is a major constituent of the bone matrix, and vitamin D is actually very essential for calcium absorption. So it's really important that we really focus our attention on how to increase that calcium and vitamin D. So when patients ask me, okay, my bone density is great, it's normal, I don't have to do anything. Well, no, we need to maximize our vitamin supplementation and make sure that we're actually getting in an adequate amount. As I shared with you, yes, your peak bone mass is built by the age of 20, 25, but we want to kind of keep it there. Even if you aren't on medications or have other medical conditions that are adding to that risk, you want to keep it there because it is without a doubt that all of us as we age will have a loss of bone. And then, can too much calcium be bad? Some controversy in taking too much. And I'll share this with you when I go into the exact numbers. So calcium, about 800 to 1200 milligrams per day is the recommendation. If you are premenopausal woman and you aren't really on steroids, your lupus is pretty well controlled, I would say about 1000 milligrams a day is fine. If you are a postmenopausal male or female, about 1200 milligrams of calcium is the recommendation, especially if you have lupus or on steroids. The way to take calcium is that we recommend getting at least half, if not more, through diet. Again, it's very well been established that calcium through supplementation is only absorbed maybe 30%, whereas calcium through diet perhaps absorbs 70%. And it makes sense because, you're chewing it, it's kind of going through your system versus a pill is much harder to be absorbed. And so if you can get half of the calcium through diet, and this is a pictorial representation of different ways to get calcium, I am sorry because a lot of these are all dairy, and I thought I had included non-dairy sources, but I will share them with you. So 1 8-ounce glass of milk, whether it be soy milk, oat milk, I don't know, there's like 9,000 different types of milk nowadays. Ripple milk I've heard about. I think there's oat, soy, what's the other one I'm blanking? Almond milk, thank you, a lot of them have actually more than 300 milligrams of calcium per serving. Plain yogurt, a Chobani 6-ounce Chobani has about 300. This is 8 ounce, has about 450 milligrams. 1 cup of cottage cheese, just 1 cup has 1,300 milligrams. So that's essentially your daily intake in just 1 serving of cottage cheese. 1 ounce of cheddar cheese, 200 milligrams, some vanilla ice cream, which I always think is a nice way to kind of get supplementation is about 450 milligrams, an 8-ounce glass of orange juice 300. Those of you who cannot tolerate dairy or have some aversion to it, I would suggest salmon has about 250 per about a 3-ounce serving. Bok choy, broccoli, kale all have, just in a cup about 200 milligrams. So my suggestion to patients, and I give them this handout when I meet with them to discuss their calcium, is, okay, so you can have about half of it through your diet, 1 glass of milk, 1 serving of salmon per day will get you half, and then the rest you can take as a supplement. And I will show you a slide on the various supplements in a minute. So half through diet, half through supplementation. Vitamin D, on the other hand, is a little bit harder to get through diet. If we lived in Florida or California, I would just tell you to go in the sun. However, you also have, most of you are dealing with lupus, and you can't be in the sun. We know very well that photo sensitivity is an issue. And so how do you then get vitamin D if I'm telling you sun is a good way? Well, vitamin D supplementation is actually a little bit easier to absorb, and the absorbability through supplementation is a little bit higher than calcium. The recommendation is about 600 to 1,000 international units per day. The available supplementation for vitamin D is very common. It's vitamin D3, and it's available anywhere over the counter. And then this last statement is, again, that there's been multiple studies that have shown the benefit of calcium and vitamin D. And actually that in itself has shown to make small gains in bone mineral density as well as physical activity. This is a quick picture of the types of supplementation. And as I mentioned, vitamin D is very easy. It's vitamin D3 over the counter, and you can find various different preparations. Calcium, there's 2 big differences in supplementation. There's calcium carbonate, and then there's calcium citrate. For those of you who are on a proton pump inhibitor or anything that decreases your stomach acid because you have issues with acidity, then the right supplement for you is calcium citrate, because it doesn't require stomach acid for absorption. And so calcium citrate, Citracal, is probably the brand one that most people elect to use. And again, you don't need 1,000 milligrams. You need maybe 500 based on what your diet is. Calcium carbonate, on the other hand, needs acid to dissolve. So any of you that are not taking a proton pump inhibitor or something for acid, this is the one that can be more useful. Calcium carbonate, however, does have issues with decreased absorbability, and it's a little harsher on the stomach. And so my suggestion to most patients is actually to use the calcium citrate. And then finally, I'm going to spend the next maybe 5-10 minutes just talking to you about treatment. After you've had the initial clinical screen, you've had a bone density, and it's determined that you are someone with a high risk for fracture as well as a very high risk for increasing bone loss, our main treatment go-to is bisphosphonates. And this is the most common pharmacological therapy that's used to treat osteopenia, which is mild bone loss, and then osteoporosis. The amazing thing about bisphosphonates is that they bind to the bone and basically stop that one bone cell that I was mentioning, the osteoclast, from kind of resorbing. And different bisphosphonates have different activity. So these are the ones that are most commonly that some of you may have heard about or some of you may have be on currently. There's alendronate, which is Fosamax. There's resendronate, which is Actonil. There's abandronate, which is Boniva, and then there's zoledronate, which is reclassed. And most of these are approved for the treatment of prevention of osteoporosis as well as treatment. And then this slide shows you the different formulations. So it is nice that we have some diversity in the type of drug, and whether a patient wants to take something once a week versus they want to take something once a year. And really, one drug doesn't fit all. But the amazing thing about these drugs is that they all decrease fracture risk and actually stabilize bone density. And, there's not many things in medicine that we can say, without a doubt that this will help decrease your, risk of this or that. But this is one of the most valid evidence-based treatments that there will be a reduction in your fracture risk if you are on one of these medications. The other options that you may have heard about, there's something called Prolia, which is an injection every 6 months. There's another medicine called parathyroid hormone, which is Forteo, which is a daily injection. These two agents are often reserved for people who have more long-standing osteoporosis. They may have failed some of the more tried and true treatments. They do build bone versus where the other medicines actually stop the bone loss. These medicines are known to actually build bone a little bit more. I get asked this question a lot, so I always like to talk about estrogen replacement a little bit, especially for my female patients. There is some room for estrogen replacement. Obviously, if women are having postmenopausal symptoms, vasomotor issues related to the loss of estrogen effect. That being said, as a first line for treatment of osteoporosis, we do not recommend it because there are so many other options. And so I kind of reserve it to the gynecologist or the women's health specialist to use for other reasons, but first line for osteoporosis, because of the risk of estrogen causing blood clots and uterine breast cancer risk, we avoid it. So treatments, obviously this is the biggest issue, is the side effects. And as a patient myself in the past, and with having friends and family members that are patients, it's not fun to take a drug that causes side effects. And unfortunately, all our drugs cause side effects. So I just want to share with you some of the editorial news that you may hear. I have a lot of patients that come to me and they say, oh, my girlfriend told me that this can make me lose, my teeth, or that I'm going to actually get more fractures because I put on some of these medicines. So how do you kind of deal with that? And again, a lot of this is a discussion that you can have with your clinician or treating physician. The biggest side effect of the medicines that I've mentioned is with the oral medicines, you can sometimes have some GI distress. So it's really important to have an open discussion with your physician if you have any of these symptoms, but oftentimes they do they do get better over time. If you do have excessive GI irritation, then we do have options, as I mentioned, for IV infusions or shots that may actually take away that as a potential issue. As I mentioned, osteonecrosis of the jaw. So what that means is that over years of therapy, some patients may develop issues with healing, especially after dental extractions or invasive dental procedures after they've been on this medicine. It was actually first reported in probably 2003, and there have been subsequent reports of these in patients who are actually getting higher dosed medicines for osteoporosis because of malignancy related bone loss. The reality of the situation is that there is a causal link. The current guidelines suggest whenever I start a patient on these drugs, I give them that potential risk. However, it is not, the number needed to really prevent fractures is much higher than what happens with this risk. So I advise patients to get good dental hygiene. If they have a major procedure planned, and such as an extraction or an implant, then I actually withhold and don't start the therapy until a few months later. But if you're already on therapy and you're getting, cavity fillings, minor dental work, there's really not an issue. And then the other scenario is sometimes I've had the dentist or orthodontist reach out and say, okay, this patient's been on this drug for a while. What do you think the risk is? What do you think we should do? And sometimes we hold hold the medicine for a few months while they're getting the procedure, and sometimes we don't. Again, very case-based. But the risk really, especially initially within the first couple of years of therapy, as I said, bone loss changes very, very slow. So within the first few years of therapy, it's very, very unlikely. And then the other real big editorial news that you'll hear about is this risk of more fractures. So why would you get more fractures when you're on a drug to prevent fractures? And there's something called subtrochanteric fractures, which can occur basically at the femur. And again, the conclusions, I'm not going to kind of go into all of it, but the conclusion is that really, again, for the number of patients that you prevent a fracture in, an osteoporosis fracture in, is much, much higher than those that develop these atypical fractures. The goal, again, is a discussion with your patient, your provider. We have found that the patients who do develop this are the ones on long-term therapy. So that means over 5 to 10 years. The role for what we call a bisphosphonate or a osteoporotic drug holiday is really important in talking about these risks. So we know that if you kind of stop bone loss too long, that the body thinks that you're not making bone, and then there's this state of almost what we call a dynamic state, and that's where this risk becomes high. So again, as treating physicians now doing this and having these drugs around for so long, we understand that these are risks, but it is that drug holiday that becomes very important to prevent it. And then finally, can osteoporosis be prevented? I get asked this question a lot. And unfortunately, no. I mean, as I mentioned, it's age, it's ethnicity, it's genetics, it's your medical conditions that actually predispose you, and the medications. Those of you who have already had a baseline DEXA, you have some degree of knowledge of where you're at. And if you're already osteopenic, does that mean you are going to develop osteoporosis? There is no guarantee of that. Some people stay at that level for years. And so the final point is that the screening is so important, and then the repetition of that bone density. So evidence-based requires you to get it at least every 2 years. Why not sooner? It's really interesting. Bone density just doesn't change that fast. It's a very stagnant process. So every 2 years is enough. Some clinicians may elect to get it perhaps every year if you perhaps are, let's say, on a holiday, or you just started steroids and they feel that your risk may be higher, but every 2 years is recommended. This is just a quick picture of our osteoporosis center here at Rush. We do our DEXAs on site, and we also have an infusion suite where some of those medicines that I mentioned to you, the Prolia, which is the shot, and then the infusion, which is the reclass or zoledronic acid, is given. And then here are some references. The NOF website has wonderful, wonderful patient resources. Some of those pictures that I showed you on lifestyle changes on how to just sit at a desk or how to lean on a table are there. And then again, our website. So with that, I have left some time for questions. I'd be happy to take any questions or have any of my colleagues give any other pearls of wisdom.
Thank you so much for that presentation. And we actually do have a couple of questions. Here's one that I received. I've been diagnosed with osteopenia, and the rheumatologist advised that I take Boniva. My Part D drug insurance refused to cover it. The dentist advised not taking Boniva because it could cause bad things for the bones. I did not press the issue because I figured I'm only diagnosed with osteopenia, not full-blown osteoporosis. What can you advise?
Okay, that's a wonderful question, and definitely a scenario we see often. Again, without all the medical history, this is very much hard to know why your prescribing physician recommended certain things. In regards to osteopenia, the one thing that I did not share, and I thought I had put the slide in, there's a fracture indice called a FRAX score. The FRAX score is something that, in addition to the bone density, can give a clinician and a patient their 10-year risk of hip fracture as well as major osteoporotic fracture. So that may be one reason why your treating physician kind of tipped the balance towards treatment, because the FRAX score was elevated. Number two, it may also be based on your medications that you're currently on, if it's active use of steroids or your length of other treatments. And then it's also change in time. If this is your second bone density, if there's been a precipitous drop from the one 2 years ago or a couple of years ago, then that may be a reason that the treating physician wants to treat you. As far as the insurance approval, we all as treating physicians deal with this. As I mentioned, there's the Boniva, but there's also alendronate, there's Prolia, there's other options. So perhaps your plan has a preferred treatment option that may need to be looked into.
Okay, great. We do have another question. Prednisone has caused my bones to be weakened. I've had several fractures and a total hip replacement at 25. What are some ways I can get my bones to get strong again?
Okay, so again, I would, if you haven't had a bone density, that's very important. It sounds like you've had osteoporotic related fractures. The medications that I've shared with you are very important in helping to kind of slow down the bone loss. But at this point, if you've already had some fractures, you may be a candidate for one of those medicines that builds bone. As far as other things, exercise, lifestyle changes, vitamin, calcium supplementation is really crucial. And then, as much as we can as physicians, we try to minimize the medicines that add to bone loss. I know prednisone is so vital and important in treating our inflammatory conditions. However, it comes with unfortunate side effects, and bone loss is one of them. So when your physicians are trying to get you off the prednisone, this is one of the reasons, because we do know it does affect the bone so much. I think those are the main things that I would suggest: is medical management, lifestyle changes. Already having a fracture is a sign that you may have another fracture. Unfortunately, it's hard to go back and to kind of take some of that bone loss away. However, as I said, we have some very good options that are actually bone building agents, and so that would be a great discussion that you could have with your clinician.
Dr. Jolly, did you want to chime in on that at all, or? I know
yeah, I mean, there are a couple of things with steroids. Of course, you have to do what Dr. Khandelwal just mentioned. Also, talking to your doctor as to what is the length of the steroids you're going to be on? What is the dose? Can it be decreased? How can it be decreased? Can I use something else in its place? Understanding of those things are very important. Also, if maintaining your appointments with your doctors, say you've been put on prednisone but you haven't gone back to the doctor, then you could stay on that prednisone for some time. So keeping your appointments and asking these questions about the plan, why I'm on prednisone, do I need this higher dose, what could be the next step, could I use something else for it, those are important. I think Dr. Khandelwal did such a great job talking about osteoporosis, but lupus related things, I wanted to just mention a couple of them. Smoking is something that Dr. Khandelwal already talked about, but smoking in lupus is also carries importance, that one should not smoke because you can get more aggressive skin conditions. Also, your hydroxychloroquine may not work as effectively if you're smoking. So that's another reason, not just bones, but if you're taking your hydroxychloroquine, which has so many benefits for lupus patients, it may not work that well if you're smoking. So that is something to take care of. The other thing is vitamin D, because as Dr. Khandelwal also mentioned, that our patients are not going out in the sun as much. Also, somebody living in, for example, in Chicago, almost everyone is vitamin D deficient. So, correcting that is important. Our lupus patients have this inflammation going on. There may be medications. They may have joint pains or muscle disease, mobility. They're not moving around as much, maybe. All these things add to the risk towards, weakening your bones. But also there is data to show that low vitamin D may be associated with more active lupus. So another reason to take your vitamin D and keep that at a good level. So very, very important, not just for your bones, but for your lupus also. So we in lupus clinic check people's vitamin D. I mean, I don't have lupus, but my vitamin D runs so low. So even I have to end up taking that.
So when you're, I'm
Yeah.
sorry, pardon me, go ahead.
The third thing I want to say is a lot of times, patients with lupus are on so many other medications. Calcium and vitamin D are the first to be dropped off the list. Like, okay, fine, I'll take this tomorrow. I have so many of them. So it falls off the list very quickly. Also, patients say that taking these big chalky pills, is hard. So they drop taking calcium or vitamin D. But there are several alternatives that are available that are also, interesting ways of taking your calcium if you don't have diabetes or anything. Like I have lactose intolerance and I take my vitamin D and calcium as chocolate nuggets or caramel nuggets. So, find your way. There are many different ways of taking it. So don't give up on this just because, it's one of the medications lower down in your list, or because you feel these are large pills or chalky pills.
Okay.
Yeah, I'll add to that. The vitamin chews, I think someone's asking that question in the chat also. I completely agree. The solid vitamin supplements are a little bit harder to take, and as I mentioned, the absorbability might not be as much. Bioactive is the calcium chews. They come in chocolate and caramel, and they're great. They're about 400 milligrams of calcium per chocolate or nugget. In regards to, there's other, and I'm not giving a shout out to Amazon, but they have so many options for calcium chews, and they're so much easier to take. Again, for those of you who are pre-diabetic or diabetic, just check the sugar content on some of those, but they are very much easier to tolerate and
Yeah, me
easier
and Dr. Khandelwal don't have any stocks or shares in Viactive, but Viactive does also come with D in it. So with one chocolate nugget, I use it like a dessert for me. I put it on my dining table, have one after lunch and one after dinner, and I'm done. So, work out a way that you can do things, right?
And I guess one more point to that, I think I said it in my slide set, but calcium and vitamin D are better absorbed if you separate it. Again, because of that absorption issue, it's better to separate. So that's the whole point of kind of dividing it out and doing some through diet, some through supplementation. You get actually more, what we say, bioavailability, so more of your body can use it.
Okay. Another question, what if you're dealing with sprains of the ankle? Should I do the elliptical or walking or both? Which is best?
Sprains of the ankle, that's an interesting one. I mean, I think that probably either is fine. He might be an issue with supportive shoe wear. I think that sometimes perhaps elliptical is a little bit more kind of controlled, whereas walking, depending on if you're walking on a uneven path and stuff, you are more likely to be sprained. But really, in regards to building your bone mass, either of those would be good. And I often just share, you need to kind of go slow and steady is the goal.
Okay. Another question, you kind of answered this. I'm sorry, did you?
Having dealt with ankle sprains, I can tell you that if you have access to a treadmill, then not on too much incline is something that you can do, which is better than your elliptical or walking outside.
Okay. Another question, you kind of touched on this. Do we need to take medications when you're having osteopenia?
That's a great question. So again, probably 10, 15 years ago, that was the recommendation options. And now we've learned that actually treating too long can actually lead to some of the side effects and issues that I mentioned in my talk. So if you have osteopenia with let's say what we call a normal frax, that frax indice that I mentioned, then a physician may wait to just kind of check your bone density every year or 2 years to see if you continue to drop. But if you're osteopenia on high dose steroids, there is something called the glucocorticoid induced osteoporosis guidelines that may actually trump you over towards treatment. So again, depending on your clinical scenario, the medicines you're on, your risk of fractures, you may need to be treated.
Okay. What happens if you take too much calcium, or as I like to think of it, eat too many chocolate nuggets?
So calcium, especially calcium carbonate, I think the one in Bioactive is calcium citrate, can lead to a lot of abdominal pain. So you have to be careful for kind of just developing some sensitivity to that. There are some reports, as I've mentioned, that too much supplemental calcium can actually, quote unquote, deposit into our organs, whether it be the kidneys, the blood vessels. That's not fully evidence-based. There's a lot of back and forth in the cardiac literature, the GI literature, the renal literature about that. So you could potentially take too much. Again, I would stick to that 1200 kind of as the upper limit.
Okay. And then here's a question, perhaps in jest. Are those chocolate nuggets in dark chocolate?
I don't know. Dr. Jolly?
No, they're regular chocolate, but I don't know I've found anything in dark chocolate. But there are a lot many other flavors. It's not just chocolate. There are very many, and I don't have any shares in it.
Well, they do sound delicious. But then again, if we say chocolate one more time, I'm going to have to go running from the building to the convenience store.
Yeah.
A little bit of a chocolate hog. All right, so I think that's all of our questions. Are there any other, I guess one thought I had for you, Dr. Jolly, because prednisone is so linked with osteoporosis, when you first prescribe it, how do you talk to your patients about it? And do you bring it up at every visit? Do you only bring it up when it's an issue?
So when we start prednisone, there is a serious thought process as, before we even talk to the patient, does the patient really need prednisone? Or is this something that can be managed in other ways? There are situations where a patient needs prednisone and there are situations where they need a lot of prednisone. But then we decide, okay, we talk to the patient and we decide that, okay, we are going to start you on prednisone. And this is the reason why we think you need to be on this sort of dose of medication. Agreed, it has side effects, but our plan is to keep you on it for, 2 months, 3 months, and then start to taper it down. And this is, in situations where you have some of the organ of their body which is at risk for permanent damage. So it is to prevent those kinds of permanent damage. These are major organs, whether they have any brain involvement, or kidney involvement, for example. So it is to prevent that. So in those situations, you talk to the patient why we are suggesting. We talk to them. This is why we are suggesting, because there is a lot at stake right now. And if we don't do something right now, there will be damage which we cannot prevent then. And if we start other medications, yes, we will start other medications to reduce the prednisone dose, but those medicines usually take time to kick in and build up the dose to that level. We will definitely do that, but prednisone works quicker. So it's like putting a fire. When there is a fire happening, you need to pull in emergency supplies to put that fire down. But at the same time, you need to look for any leaky faucets here, there, that the gas, that or whatever is contributing to the fire. So you do bring in other medicines. You talk to the patient, these are the side effects. You can get weight gain, you can get acne, you can get hair loss, you can get weak bones, blood pressure, irritation of the lining of the stomach. You go over all of those, but you give them a plan that this is the diet what you would manage, this is calcium, vitamin D you need, If you're on prednisone to prevent pneumonias, you need this medication, this antibiotic. And then at every visit, any patient of mine or ours in the lupus clinic that is on prednisone, we do at every visit, think about it, whether they need to continue on prednisone and at what dose can this be reduced. So that is what we do. Unfortunately, some patients need to continue on prednisone. Then we do, like, if we can't get them off, then what is the least amount of dose that will keep them under control, that has the least amount of side effects for the long term. So
Okay.
those are some things.
Mary, can I add something, please? This is Dr. Nika.
Nika.
Yes, I get a lot of questions from especially younger patients when we order the bone density, and it might be normal every 2 years, every 3 years. When it might be normal, or they are in the range of osteopenia, low bone mass, but not low enough to treat. And patients ask, why then we are getting this test every 2 years? When we compare the test, when we do the testing every so often, we compare it with the previous one, and when we see that there is a decline in the bone density below a certain threshold, we see that something might not be working, or it needs to be addressed, like the calcium and vitamin D intake, or they might be on a prednisone dose. And this is one more of a reasons to think about adjusting the medications and adjusting the prednisone dose. A lot of these patients are young, and despite everything else, they have contraindications for some medications. So like bisphosphonates might be not used in women of childbearing age, and so we have a lot of limitations. But the reason we do the bone density is because there is so many other factors that we can revise and do differently.
Okay, wonderful. Thank you. All right, so we are that's the time for this one. We will post this to the website, and we will and that should be done sometime next week. But thank you so much for this. I actually got I don't know if you can see all the chats, but I did get a couple of people chatted to me. Thank you so much for this presentation. So you were a hit.
Oh, you're very welcome. Thank you for inviting me.
Of course. Thank you so much. Now, we are going to take a break. Also did want to thank our sponsor. GlaxoSmithKline, GSK, was kind enough to sponsor our educational events this year. And their representative, Lacey Griffith, is on the call today, learning along with all of us.